Hello, this is Louise. I'm talking to Dr. Nelken today. He's a vascular surgeon at Kaiser Permanente. Thanks for taking the time to talk to us, Dr. Nelken.
Well, thank you very much.
What surgeries do you perform for people who will be undergoing kidney dialysis?
I do hemodialysis work. There are a number of different procedures, but we do something called a fistula, which is the use of a natural vein within your own body to increase blood flow so that you can be put on the dialysis machine. I do graft placement, and that's if your veins aren't suitable for use, we have artificial veins that can be used. And we also put in catheters that can be used in other situations. There is also peritoneal dialysis, but I don't do that work.
What kind of preparation should a person expect before vascular surgery?
I think the most important preparation is to make sure that the patient understands what is about to happen to them. A lot of people come to see me for this kind of work, some of whom really have no idea what is about to happen. And I'm actually glad that we're doing this, because this is a way that people can look at the process before they come to see a vascular surgeon in order to understand a little bit about it. I do explain everything as best I can in the time that we have, but there are limits to the amount of time that you can spend with any one patient in a pre-op situation. So educating yourself as much as possible, and I'm sure your nephrologist will help you with that, about the process is very helpful. Where I work at Kaiser Permanente, we have a class where people understand what the various different choices are. And it's very helpful when the patients come to see me if they've already taken that class before they see me.
What do you evaluate in a patient before deciding what type of surgery is best for them?
Well, the patient has a number of different variables, all of which need to be done. First and most simply are the physical variables. What kind of arterial inflow do they have? What kind of veins do they have to take the blood back? What is the condition of their arm? Many of the patients that come to see me, unfortunately, have had many hospitalizations, and they have a lot of scarring from previous intravenous lines. We evaluate the patient's ability to understand what is going on and how they will be able to cooperate with care. Hemodialysis is a tremendous involvement in time. So generally, patients have 3 sessions per week. On average, the session on hemodialysis is about 3 to 4 hours per. And then, of course, there's coming into the dialysis unit and leaving the dialysis unit. So the total amount of time per week is quite a bit. And so people's ability to transport, people's willingness to participate, et cetera, all of these things are terribly important. What I deal with in my clinic mostly are the anatomic variables, arterial inflows, status of the skin, venous outflow. And by looking at those things in the clinic, we get a much better idea about which of the various operations that we perform are the most appropriate. Now, one of the things I do when I see patients, besides describe what's going on, is we have a portable ultrasound unit in the clinic, and I can do ultrasound right there in clinic and get a much better idea as to what it is that I'm looking for. From time to time, a patient's anatomy is so complicated that in the limited time that one has for a visit, I then need to send them to the vascular laboratory for a more official and detailed ultrasound study. I would say about 75% of the time I can answer the questions that I need to know right there in the clinic using ultrasound myself. And about 25% of the time we need to send them to the vascular laboratory for a detailed look.
What are the major differences between a fistula and a graft from the patient's perspective?
The So I should begin, I think, by describing what happens in hemodialysis so that people
Okay.
understand the dynamics, and then move from there to the anatomy. So the hemodialysis machine takes the blood out of the patient, puts it into the machine itself where the blood is filtered, and all the poison's taken out, and then the blood is returned through other tubes back into the body. This requires a tube coming out and another tube coming in. The blood is pushed along by rollers, and so there are two axes. In other words, if you have access in the arm, two needles go in, one for the blood coming out and one for the blood coming back in. If you have a catheter, these are catheters that have two lumens, and so simultaneously the blood can come out of the catheter and go back into the catheter at the same time. Now the dialysis machine is pretty thirsty. It goes through about, and this is very, very general, but it goes through about a pint a minute. And since the arm does not have a blood flow of a pint a minute, we have to set up a situation where the blood flow in the arm is much faster than it normally is. So just for example, the average blood flow in the arm at rest is about 100 cc's a minute. And after we put in either the fistula or the graft, we're happy if it's about 600 to 1,000 cc's a minute. So we increase the amount of blood flow in the arm by quite a large number. And that allows the thirsty dialysis machine to be satisfied. So the difference is the fistula is done, and we prefer a fistula because it's natural. The fistula is using your own veins. And so what we do is we put the artery and the vein together. So in other words, we short circuit some of the blood flow. And because the blood is no longer hindered by the resistance of the small blood vessels, the blood flow increases dramatically. Now, fistula, being natural, is terrific if it works, but people come with all manners of veins. Some people have been very scarred up because they've had multiple prior hospitalizations. Some people have very tiny veins to begin with, and they're just not suitable for a fistula. So if the patient has suitable veins for a fistula, we do like that better. If they do not have suitable veins, then we can use something called a graft, which is an artificial conduit. It's an artificial blood vessel that we can put in order to allow the blood to go through that.
I've heard a fistula needs to mature after the surgery. What's happening during that maturation?
So everybody has seen photographs of athletes with gigantic veins. And one of the reasons that they have these gigantic veins is that those veins have recruited over time because of the tremendous increase in blood flow in the extremity that those athletes generate when they're doing their athletics. Turns out that when we put the artery and the vein together, not only does it greatly increase blood flow, but the blood flow in the vein creates the same process. And so it essentially recruits these blood vessels to enlarge over time. That's what we want. We want something that is easy to puncture by the dialysis unit, but that process typically takes at the shortest 6 weeks and at the longest 6 months in order to occur.
For the surgery itself, is that an outpatient procedure? Does the person undergo general anesthesia? How does that work?
It's an outpatient procedure. Patients come, they have surgery. The postoperative recovery is generally only about an hour or so, although like everything that varies, and then they go home. Where I work, we do mostly local anesthetic with sedation. And so when I talk to people, when I see them back in clinic or if I see them in the recovery room, frequently they don't remember what happened in the operating room. Some people like to be done completely under local. In other words, there's no sedation at all. And of course, those people remember everything, which is fine with me. Very occasionally we do things under general anesthetic, but that's pretty unusual.
How long does the surgery itself take?
I'll say about an hour. It varies tremendously with how complex the anatomy is, but an hour is approximately the right amount of time. Grafts take a little bit longer because there are two connections. In other words, you connect with the artery, goes into the graft, and then you connect with the vein for the outflow. And the fistulas are a single connection, otherwise called an anastomosis. And the single connection obviously takes less time than doing two connections between the two.
If you're rerouting the blood flow from the artery to the vein, does your hand lose any blood?
That's a great question. And so there is, for the most part, the answer is no. But nationwide, approximately 5% of people have problems with that. And so this requires a little bit of explanation. Some people have limited arterial inflow. And if they have limited arterial inflow, then when you shunt the blood away from where it's going, sometimes the artery is not able to supply enough blood for the fistula as well as the hand. Now that's called appropriately steal. In other words, the fistula is stealing blood away from the hand. And the good news is it only happens about 1 person out of 20. The bad news is if you do a lot of this work, which we do see steal phenomena. So I make a big point of teaching people ahead of time what the symptoms of steal are, and they come, as you can imagine, in various different degrees of severity. The mildest is your fingers might be a little bit cool. After that, you might feel a little bit of tingling in your fingers. Those are benign things, but annoying, and patients don't particularly like them. Sometimes you recruit in such a way that you feel that for a couple of weeks and then it goes away. More serious is real numbness of the fingers. You need to be able to use your hand, obviously, when you're done with this. After you do an operation, obviously you have some discomfort at the area that the incision is, but if you have pain in the hand itself, it means that blood is being stolen from the hand to the degree that the hand isn't getting enough blood on its own. And so I'm very careful to describe to patients that if they have pain somewhere other than where I operated, they should report that immediately. And the most severe is inability to use the hand. And in that case, people need to report that immediately, day or night. Because if that goes on for more than 12 to 24 hours, sometimes that can be permanent. So I check in the recovery room to make sure that it's not happening immediately, but sometimes I get calls from patients at night that they have a severe outcome. And usually what you have to do in that situation is tie off the fistula. Not all of them, fistulas or grafts, not all of them can be used. And I wish we could predict more accurately in advance which people are going to be great candidates at some point, because the operation is not such a large operation. At some point, you have to just do it and see how things go. But you need to make sure the patients understand what's about to happen to them, so that if they're one of these few patients that have this problem, they know to report it day or night, and not go home and say, well, I have an appointment next week, because by the time next week comes, it might be too late.
Going back to the surgical procedure, when the artery is connected to the vein, are they really just cut and the two ends stitched together?
Well, there are various different ways to do this, all right? The most common way for a fistula is to do something called an end-to-side connection. So in other words, we have the side of the artery. I want the artery to continue to supply blood to the hand, just like we discussed. And so I don't want all of the arterial blood to go into the fistula, only some of it. And so I take a vein, I cut the vein, and I put it on the side of the artery. So if you have the artery going like this, and then the vein comes off like that, so that the blood will go down the artery to the hand, but it will also go up the fistula. So just by way of review, the artery brings blood from the heart to the periphery, and the veins bring the blood from the periphery back to the heart. And arteries and veins are very, very different from each other. I know if you're not a vascular surgeon, you probably think they're the same thing. In my mind, they're very, very different because they have different functions, they look different, they behave differently. I don't expect the patient to understand that, but I'm trying to explain this, that the artery brings the blood to the hand and to the fistula. The vein brings the blood back.
Besides stealing blood flow to the hand, are there other complications of the surgery?
Well, anytime you break the skin, there's a possible risk of infection, and this goes for any operation. One of the reasons that we like fistulas, if they're appropriate over grafts, is that a fistula is done with native tissues, in other words, stuff that you were born with. And the advantage to that is that your body is much better at fighting infection if it's fighting infection from your own tissues than if you're fighting infection from an artificial device. The problem with artificial devices these days is, for the most part, bacteria are pretty good at hiding out in these things. So if you get an infection in an artificial graft, many times we have to take it out. So long-term arteriovenous grafts do have a complication rate of infections, and those can be fairly dramatic. Fortunately, it doesn't happen all that much. The dialysis units are very good at using extremely clean technique when they puncture these things for dialysis access. But understanding that there are 6 punctures per week, in other words, 2 punctures for 3 visits per week, there is in fact a lot of opportunity for bacteria from the skin to be introduced into the graft. And so that's probably one of the most important complications. After that, eventually there's scarring of the skin where the punctures are. And we advise patients how these things should be punctured so that they understand what's happening, so that the scars are nice and even, and that the same part of the graft isn't punctured again and again and again, because eventually anything will wear out.
Is the graft made of plastic?
Well, it depends which device, but most of them are actually made of Teflon. And so it's called PTFE. PTFE is the parent compound of Teflon. It is heated and it's pushed through a pressure device, and it comes out looking a little bit like a marshmallow. Believe it or not, it's porous, and so it's porous Teflon in a tube shape, and then we sew those into the artery and then sew it into the vein.
Okay. Do you ever place a fistula or a graft somewhere other than the arm?
Yes. Now, some of this depends a little bit on the dialysis unit, what they're used to dealing with. And so we work in concert with the dialysis units. I work at Kaiser. We don't own except on Maui, we don't own our own dialysis unit. And so we do work in concert with the dialysis units that we participate with. And for some of these patients, when we run out of access sites on the arm, we can do this on the leg. There are other very rarely used anatomic configurations that can be used, but for the most part, you have a forearm, you have an upper arm, you have one of those on each side, after which we start using the lower extremity, generally the thigh. The problem with the lower extremity is a lot of these patients also have hardening of the arteries, otherwise known as atherosclerosis. And atherosclerosis generally presents itself in the lower extremity a lot more than the upper extremity. And so we have to work around that from time to time because it's much more troublesome in the lower extremity to have steel if it is in concert with a patient who also has hardening of the artery in the lower extremity. Now, the practice that I have here in Hawaii is we of course deal with all patients who are on hemodialysis, but here in Hawaii, diabetes is predominant. And diabetes is also associated with hardening of the arteries or atherosclerosis. And so we try to stay away from the lower extremity if possible.
Do you ever run into someone who simply can't get a fistula or a graft or has exhausted all of their options?
We do. We're pretty creative at working around this, but eventually there are patients. I mean, I've been in attending since 1992, and so as you can imagine, I've seen all kinds of various situations. Some patients can only have hemodialysis done through a catheter. Now, a catheter is a completely different situation. What we do is we take a long intravenous catheter and we put it into a central vein. And so generally it goes in an area somewhere around here, goes up and into the jugular vein, the tip of which then goes down and sits very close to the heart. And you're probably wondering why that is. And the reason is those are some of the only veins in the body that in their natural state have enough blood flow to satisfy the thirsty dialysis machine. If you try to put that in a peripheral vein, the machine sucks the blood out so quickly that the veins collapse and you can't actually get the blood flow. We try not to have patients on catheters if possible, because since it goes in through the skin, the likelihood of infection with a catheter is higher than the likelihood of infection with either a graft or a fistula. But we have a population of patients who simply cannot be dialyzed by any other means. Now, if you bring this discussion to its logical conclusion, are there patients who use up all the sites for the catheters? And indeed, there are some very fancy placements, things that I end up doing probably once every 5 to 10 years in patients who have really exhausted all of these supplies. And it's probably not worth it to discuss the anatomy of that at this point, because these are exceptions and not the rule. The rule is fistula if we can do it, graft if we can't. If we can't do that, we move to areas of the body where we can. If we can't do that, then we go to a catheter. And if we can't put the catheter in, then either peritoneal dialysis or some fancy solution.
What do patients need to do when their fistula is maturing?
We tell most patients to check their fistula every day. And the way you do that is you just feel it. The blood flow is quite fast in these things, and you can actually feel a buzzing. And this buzzing is a good thing. It means that the blood is flowing very quickly. Needless to say, neither the artery nor the vein were initially designed for that fast of blood flow. And so the buzzing is something you're not used to feeling. But we teach patients what this feels like, and then they just check it every day to make sure that they still have it. The buzzing can change in quality, and that's related to various different factors about how the fistula is maturing, or whether there are blockages which are occurring within the fistula or things like that. And it's probably too detailed to go into here, but we do have patients who are the first people to let either the nephrologist or let the vascular surgeon know, yeah, something's changed about my fistula and I think it ought to be looked at.
I've talked to some patients who have told me they get a squeeze ball after the fistula surgery. Is that something you recommend?
The squeeze ball, so we talked about athletes before, and the squeeze ball, it's not that athletic, but it does increase the blood flow to your forearm. Whether it has a meaningful change in blood flow, we're not exactly sure, but it certainly can't hurt, and it increases exercise. I think exercise, for the most part, is almost always good for patients. Whether or not it improves blood flow, having a patient exercise that extremity is good. The goal of either arteriovenous graft or arteriovenous fistula surgery is to have an extremity which you can use in an absolutely normal way. So do I have heavy construction workers who have fistulas? Absolutely, we do. And a lot of times patients will come in and say, does that mean I have to stop playing golf, or, do I have to stop working? And the answer is, if this works the way it's supposed to, no, you should be able to continue working or playing golf or tennis or whatever you'd like to do.
Do people need to take any special precautions to protect their arm and their fistula, just in general?
A certain amount of familiarity of the bad things that can happen needs to be taught to the patient. So we already talked about feeling the buzzing versus various other sensations that you can have here. The second thing is the steel phenomenon. Very, very rarely you can have a perfectly fine fistula that very slowly recruits over a very long period of time, and steel can develop 6 months to a year on down. Now, that's very rare, but it can happen, and patients need to be aware of that. Sometimes patients can get infection. So since it's punctured in 6 places every week, sometimes an infection will occur. Sometimes there's crusting that can occur because that connects with blood and there's a little bit of blood left over. Sometimes there can actually be breakdown of the fistula. Unfortunately, sometimes when the fistula is poked, some blood can leak out into the space of the arm, and that can cause a swelling there. Either it's still liquid blood, in which case it's something we call a pseudoaneurysm, which is kind of blood swirling around in that area. Sometimes it can just be a collection of the blood, but all of those things patients need to be familiar with and to report. It sounds complicated if you've never been exposed to this, but if you're going to the dialysis unit 3 times a week and you also see people around you, patients are pretty good about picking up fairly quickly the things that they need to focus on. Also, despite the fact that we tell people this, they have a tendency to forget. I get that. This is, complicated, and they're not experts. But they tend to be reminded, by the technicians or the nurses at the dialysis unit, who also are trained to look for these things. And so the patient often reports problems. The dialysis technician or the nurses often report problems. Sometimes the nephrologist who sees the patient on a regular basis reports problems. So there are a lot of eyeballs on the access on a regular basis. Now, we follow fistulas and grafts until they're ready for use, and then we no longer follow these patients until they need something. Okay. And a lot of patients are told, well, why don't you go to the vascular surgeon, and he or she is going to put in what they call the permanent access. And I hate to report, but there is no such thing as permanent access, okay? These things all have a lifespan, and I can tell you in the United States, a fistula, on average, with a lot of variability, lots of variability, needs some kind of work about once a year, and a graft, on average, needs some kind of work about every 6 months. And that's another reason why, if you have the veins for it, we prefer to use a natural fistula over a graft. Now, this can vary a tremendous amount. We have people who have particularly sticky blood and some genetic syndromes where their blood doesn't really wish to cooperate, in which case we have lots of thromboses and have to deal with this on a regular basis. We also have some patients where it's one and done. I put a fistula in, and the thing finally wears out after 10 to 15 years, and then I see them again. So hopefully you'll be one of the latter kind, but there's no way of predicting initially what will end up happening. But those are the averages.
So you mentioned thrombosis. Does that happen mostly with grafts?
Well, that's a great question. So just to explain the word thrombosis means blood clotting. And so you've got blood flowing through this circuit at more than a pint a minute, sometimes a quart a minute, sometimes a quart and a half a minute, really very quick flow. Now, within the conduit, sometimes there can be scarring that occurs over time because we operate on the body, scars occur. Everybody understands that on the skin, but it turns out the same thing happens within the body itself. And because the blood is flowing very quickly, not everybody's blood vessels increase in size with the increased blood flow like that of an athlete. Sometimes the increase in blood flow causes turbulence, so the turbulence causes damage on the inside of the vein, and so the opposite happens. grafts, over time there's scarring, and the blood flow can actually over time become less and less. And so we deal with all of these various different problems. Grafts tend to thrombose more than fistulas do. They're artificial materials, and although there's all kinds of great science, in fact, there's a compound called heparin which prevents thrombosis, and they actually have molecular ways of bonding heparin to the inside of some of these dialysis grafts. None of these things is foolproof, and so those numbers I said before, in other words, grafts usually need something about every 6 months, and fistulas about once a year. That's the average that I tell patients. Dialysis is a major undertaking. If you're a patient and your doctor says, I think that we're moving towards dialysis, the patients of mine who do the best are the patients who understand the most about what's about to happen to them. And so, believe it or not, I have patients who start out being regular lay people, as most patients are, who, regarding certain aspects of their care, end up knowing more about those particular aspects than I do. And you might think, well, that's crazy. You're the doctor. Why would that ever happen? Well, I have a breadth of knowledge. I do a lot of this kind of work. But when you're the patient, there are particular things that will interest you more because these are things that are happening to you. And so patients who have a lot of curiosity about the process, who really understand what's going on, who ask me a gazillion questions in clinic, who really try to understand the mechanics and get back to me, those are the patients who tend to do well. Initially, the patients who really want to understand what's going on before the visit to the vascular surgeon, they understand a lot better what questions to ask me and the things that I can explain to them. Believe it or not, there are choices that patients make. Some patients, they do or don't want particular things. And we can usually accommodate some of those requests. So having an understanding of what's about to happen is really important. Now, I understand we have a lot of patients that when the nephrologist says, well, we're kind of moving toward dialysis and we're probably going to have you see a vascular surgeon, as soon as the word surgeon comes out of their mouth, it makes the patients fearful, and I understand that, and it makes perfect sense. It's difficult for some people to get over that fear, and what they try to do is to avoid the problem. Yeah. If you're heading towards dialysis, it's very unlikely that you will avoid this problem lifelong. Now, we're not very good at predicting how soon you need to be on dialysis. That is something that there is a lot of science behind, but again, it's still a very educated guess. So when the patients come to me and they say, well, exactly when am I going to start dialysis? For the most part, I don't know the answer to that. Now, there are patients whose kidney function is going down so fast that I can say, yes, within the next month or so, you are almost certainly going to be on dialysis. And especially patients who are symptomatic. In other words, they're short of breath and things like that. But my best advice for people who are working with a nephrologist over time, trying to prevent dialysis, is when the nephrologist finally says, I think it's time that we moved on to the next stage, and I'm going to send you to the vascular surgeon to evaluate you for the appropriate dialysis access. That at that point, get interested and read all you can about it, ask everybody appropriate questions. If you know somebody who is a patient on dialysis, pick their brain. People are usually very eager to talk to people about the experiences that they have and the things that they like about their care or they don't like about their care. All of this is incredibly valuable information for you if you're moving in that direction.
You mentioned education. Do you have information sources you recommend to patients so they can become more informed?
Well, I work at Kaiser Permanente, and so we have these, it's called the choices class, and the choices referring to the choice of the types of dialysis that you might end up getting. There are lots of sites online. I don't have anything at my immediate beck and call, but there's a lot of information about this online. If you are not in the Kaiser system, which many people watching this will not be, understand that the amount of resources that go into dialysis are so vast that almost certainly any nephrologist is in a system of some kind. The expenses to the government are so high, and the expenses to the medical systems are so high for dialysis, that they tend to put a lot of programmatic energy into making sure that the patients are prepared as best they can be. And so I know of no system that is working here in Hawaii that does not have its own information sources, its own backup plans, its own ways of helping patients through this fairly complex system.
That's really great to hear. I'm happy about that.
Yeah, I'm happy about that too.
What is anastomosis?
So I'm sorry, I lapse into medical speak, whether I like it or not, and it's a disease I have. It comes along with medical school. If you connect two blood vessels together, the connection is called an anastomosis. That's the word that we use, and it just rolls right off my tongue, but not everybody's tongue. So wherever I use that word, it means the connection between, in this case, the artery and the vein, or the connection between the artery or the vein and the graft. So those connections, they're surgically created. So in other words, we sew the tubes together. That connection is called an anastomosis.
Dr. Nelkin, thank you so much for explaining this to people. It's a specialized area of medicine, and it's great to have your expertise and explanation of it. So thank you.
Well, thank you very much for the opportunity. I'm very happy that this will be available for people to see ahead of time. I think it will help them in understanding what the process is. And I wish the best to anybody watching this who is about to undergo dialysis. And thank you very much for having me.
Okay. Thank you.